to the PODdoctors. I'm Dr. Damien Dauphinee. I'm here with my partner,
Dr. Raafae Hussain.
And today we're going to talk about a very common problem that we see all the time, both by itself and then also in combination with other forefoot deformities, the dreaded hammer toe.
Yeah, hammer toes. It's a cosmetic problem. It's a physical problem. Can cause sores and tenderness and pain. But let's go through some background information on hammer toes.
Sure.
So what is a hammer toe?
It's kind of I got that generic term for, any curvature of the great toe, but there are sort of subsets of this. So this is a great slide here talking about the subsets.
So a classic hammer toe, textbook definition, we're talking about a flexion deformity at your PIP joint. So that's your first joint after your metatarsal phalangeal joint. Your mallet toe is the opposite. It's a flexion deformity at your DIP joint, right. Your distal interphalangeal joint. And that's a flexion deformity that you can see that almost looks like, your classic mallet, like that little hammer. And then your claw toe deformity is the combination of both of those problems. Generically speaking, most docs will use the term hammer toe
kind of across
for
the
everything.
board.
Yeah.
Right. But they're specific in that the surgical answers for those need to be specific to the particular version that you might have. So there's just subtle differences between those procedures, but they would have to be specifically designed for each one of those deformities.
So why are hammer toes a problem? So classic, problems associated with hammer toes are your pressure on shoes. My shoe is rubbing against the top of my toe. As you can see here, I'll rub against the top of the PIPJ joint. Right here, another prime example. If you're a diabetic with the diabetic neuropathy, the autonomic muscle weakness and loss, you can get the hammer toe forming. And with the neuropathy, it can rub against the shoes. You can see the distal tip ends up being a problem also.
Or where the ulcers are threatening the toe, the foot, and potentially the patient's life. These are obvious entry points for infection, and it's very, very easy to have the joint involved with those, where you could end up with a septic arthritis that would cause you to potentially lose the toe.
Your toe has very little skin, and the combination of the neuropathy, which usually starts in the toes, and the loss of good blood flow, which usually starts in the toes, that causes that sore to be very difficult, very time-consuming to heal. But the trick is, knowing what the problems are, offloading those areas, getting good blood flow down there, and then obviously basic wound care, and we can get these things to heal.
So I have a patient I'm doing a surgery on Friday for exactly this. He has a distal tip lesion on his third toe, and he's got calluses on his fourth and his fifth. He's diabetic. This has been threatening him for 6 months.
Oh, wow.
And we've been trying to get him into the OR because clearly this is about a 30-minute surgery.
Yeah, and I'm sure he didn't even realize he had the problem initially until
I couldn't feel it. Well, but I have been counseling him every week for 6 months to say, hey, look, we're getting nowhere with this because it's a mechanical problem and you can't get the wound to heal. He's obese. It's physically impossible for him to stay off his foot. Yeah. He lives alone. Classic example of someone who doesn't have a lot of social help, and until we get him in the OR and correct the deformity, he's going to continue to be threatened by this toe wound that could get infected at any moment and threaten his entire foot. He's very fortunate. It's taken very close weekly care. Expensive. This is 6 months we've been, messing around with this, but the patient was refusing surgery, so there's nothing I could do. But every day this was open was another chance for an infection that could have threatened his toe.
Yeah, that's why we try to address these as early as we've seen them. You start getting that little callus on the tip, we're like, all right, we got to figure out a way to take the pressure off of this toe.
And sometimes you can do that with diabetic shoes in diabetic patients, and we clearly tried that, and it failed miserably because his toe is so contracted.
So it's like a rigid deformity.
Oh, it's rigid. It's a claw toe. There's nothing you can do to offload the tip of the toe well enough. Even with crest pads, with the plastizoid inserts, we've gone through every iteration you can think of, and still failed. And, I could have probably predicted that from day one, but I just couldn't get the guy to agree to have surgery. So.
And the last thing that you typically see with some of these hamartos, or you'll get the little callus under the metatarsal heads. Mm-hmm. It's that retrograde pressure that, I don't know if I can show it real good. It's that retrograde pressure that pushes down when you have that hammer toe. You're walking, and that metatarsal will plantar flex and push against that ground. And over time, you start losing that fat pad, that cushion. You end up getting calluses and sores and stuff there.
And in that one you're talking about on the bottom center there, clearly that patient has a bunion as well, and probably has hypermobility.
The first ray.
So the first ray is being pushed up out of the way. He's not doing his job, and it's an overload of the second and the third. And his second toe is literally getting squeezed up and out between the third toe and the big toe. We see that often.
Yeah.
And you get ligamentous loss with that. The ligaments, they become attenuated or stretched out, or they rupture entirely. And that's when you get that crossover toe, which I know you got.
Oh, yeah, I got a good picture in here. There we go.
So
that's that crossover toe.
I try to explain this to patients. Oh, my gosh, that is
that lady, one. I don't know.
I would amputate that. There's no reason to have that.
But this is your classic crossover toe. Got that big bunion pushing over, bullying that second toe up.
And we have entire days dedicated to that problem at our national foot and ankle surgery conferences. So when you hear that should raise a red flag. That means these are that difficult to fix. So you want to fix this before you get this crossover toe, because once it's this unstable, oh my goodness, they're tough. You could do all kinds of fancy girdlestone tailors, lapidus bunionectomies, fusions of the PIP joint, all that stuff, and you could still be dealing with a toe that might need to be amputated.
Yeah. And the funny thing is, a lot of patients will come in and be like, I want to get my hammer toe fixed. It's been bothering me. And they're like, all right, we got to do the bunion. You're like, well, the bunion's not bothering me. You're like, well, it's causing the problem.
And you got to have some place to put the toe.
Yeah.
There's just no place to put the toe in that foot. And honestly, in a patient who is elderly, who's maybe not the greatest surgical candidate, amputating the second toe and maybe doing an Aiken or some other simple bunion procedure, that'd be a reasonable thing to do for that person, because the reconstruction required to actually correct that is fairly significant. Yeah. So if you've got a patient that either can't tolerate that, can't get off their foot long enough to let that heal normally, I would offer them an amputation of that toe, and they would do well. The skin would heal up in 2 weeks, and they wouldn't have a protracted post-op period.
Yeah. So when we do our clinical exam, we're looking at a whole array of things. We're looking to see if this toe itself is reducible, if it's flexible. That determines the type of surgery we're going to go and do. We're trying to see if there's an associated problem, like, for example, the bunion deformity, or if they have like a flat foot deformity, or, it could be a whole array of things. If they have what's called a haloma mole, which is like the callus between the toes, because the toes are pushing against one another. There's a whole bunch of little steps, little exams that we do to kind of see how extensive the repair needs to be. But what causes a hammer toe? We're talking about all the problems associated with, but what causes it? Your classic, shoe gear, tight, narrow shoes. Obviously, it causes the hammer toes. More specifically, causes the pain associated with the hammer toes.
Yeah, you're causing the skin lesions. So when patients come in with those calluses on tops of the toes, you have to explain to them, hey, look, these don't just pop up out of nowhere.
Yeah.
There's a very specific reason why they show up, and it is directly related to your shoe gear. You could have horrible hammer toes, and if you don't wear shoes that irritate the tops of those joints, you'll never get calluses there.
You're flip-flop people.
Right. So you'll still have hammer toes. You may get distal tip or the callus on the end of the toe because it's grinding into the ground or grinding into the shoe, but you'd never get a callus up here if you weren't wearing shoes that were contributing to the problem.
So a lot of our patients who are diabetic with hammer toes, who are not candidates or don't want to have surgery, we'll get them into the diabetic shoes that have the soft cloth type of coverings over
deep toe box.
Yeah.
So there's plenty of room for those contracted toes.
So as far as the biomechanical causes for hammer toes, there are three main reasons for hammer toe contractures. There's your flexor stabilization, there's your flexor substitution, and there's your extensor substitution. Your flexor stabilization is the most common reason. I think they estimate like 80-90% of hammer toes are caused by flexor stabilization. What that really means is that the tendon which supports your arch, the posterior tibial tendon that comes in and inserts on this bone here, comes across the back of the medial malleolus and inserts on that navicular bone. It's bringing that arch up. If your foot structure, your biomechanics, your lifestyle causes your foot to flatten out, the accessory tendons that are in the back will fire to help stabilize that arch. Now, those tendons include your flexor digitorum longus. Mm-hmm. And we know that deformity is caused by the flexor stabilization, most commonly when your fifth toe turns in. It's a little trick because your fifth toe is turning in because that tendon that's coming across your flexor digitorum longus is being pulled, and the longus muscle belly, the quadratus plani, is pulling that direction. It's a little biomechanical anatomy type of little trick that we see with this flexor stabilization type of hammer toe problem. Now, with your flexor substitution problem, it's usually in your cavus foot types, your high arch foot types. Your Achilles is weaker, and your accessory flexors are now flexing to help support that Achilles. Your long flexor tendons push off. Since they're being overused more than usual, you start getting the hammer toe deformity. And the last one is your extensor substitution, usually seen in patients also with high arch foot
with Aquinas
or forefoot Aquinas, right, or any type of Aquinas deformity.
The extensor tendons are being recruited to help pull the foot up against that tight calf muscle.
Yeah, and that's when you see the toes that are sitting high and up, and the tips aren't that bad, but you'll see like the tendons on the top of their
bowstrung.
Yeah, exactly.
Yeah, the tendons are literally like you can see on my hand. They're just popping out, but they're like that all the time. Yeah.
So the fun anatomy behind hammer toes, associated problems with hammer toes. You can get the fat pad atrophy. You can get the calluses. The fat pad atrophy, I feel like, is very under talked about.
Yeah, and it's not necessarily, it may atrophy, but it's also just dislocated.
Dislocation, yeah.
It's dislocated into the sulcus. So that's a great picture. Those are awesome. That really does describe, why you get those horrible plantar calluses. Yeah. And when that fat pad is no longer sitting where it's supposed to because the contracture is so bad, it's pulling that fat pad up into the sulcus where it's not protecting the metatarsal head anymore.
It's like you're walking on your knuckles. You got no cushion there.
And if you fix the hammer toe, you naturally see that fat pad pull back and get into a little bit better position. Yeah.
So, well, doc, what are my treatment options? We can go non-surgical, we can go surgical, and we'll run through the most common treatment options. Or we can put wheels on your feet, and you'll be perfectly fine. So conservative treatment options, there's a lot of stuff out there for hammer toe problems. Crest pads, I think, are probably the most simple type of treatment options, especially when you're getting that callus on the tip of your toes, that pressure from the hammer toes or the mallet toes kind of beating against the ground. I use these quite often in my patients with the diabetic ulcers and sores and stuff. Mm-hmm. I'll do my basic simple dressing over the toe after I've debrided everything, and then I'll get them a crest pad to take the pressure off. That allows the toes to kind of float rather than hit the ground whenever they're walking. There's a lot of splints and stretching devices out there. I think this is meant to help stretch the flexor digitorum longus tendon. I don't know if they really work. I would hope maybe they work a little bit, but honestly, you're kind of fighting something.
Long term, I don't know if that's going to do the trick. The forces that are acting on the digits are pretty extreme, and that's probably not going to give you a long term solution.
There's these little met pads that come around.
Those are nice because they can help straighten the second toe at the same time pad the ball of the foot. Yeah. You also have the ones that fit over the great toe and just cover the entire fat pad with silicone gel.
Oh, actually, I didn't put that in there. But yeah, I know what you're talking about.
The metatarsal gel strap is what it's referred to as. So, and that could be a 1/4 inch of silicone gel across the entire ball of the foot, which for someone who's getting those well circumscribed or circular callus lesions, that can really help.
Yeah.
You got to break down the callus. We like to use urea cream to break down the callus, and then have them use a pumice stone or some sort of a braid or petty egg, whatever, and take those calluses down.
Yeah, because they'll come in every 6 weeks or whatever, and we'll shave down those calluses. But those calluses are going to keep on forming unless you cushion them and you stay ahead of the callus.
And in the vast majority of cases, the callus care, if that's what you're coming in for, is not covered by insurance. So you have to understand that most insurers consider that a cosmetic problem and something you could deal with on your own. If you want us to deal with it, there's usually a charge for that. Unless you're diabetic and you have severe neuropathy, that's considered routine foot care, which isn't typically covered by insurance. Yeah.
Other things are orthotics. So it goes back to that flexor stabilization option. The orthotics, although you're like, oh, well, it's not doing anything for my hammer toes. What it is doing is helping out that posterior tibial tendon so those flexor tendons don't have to fire as hard. And then we can add like met pads. So I didn't find a good picture with a met pad on there, but what a met pad does, this is stuck to the patient's skin, but most times we'll put it into the orthotic. Mm-hmm. It takes the pressure and distributes it along the shaft of the metatarsal rather than the head of the metatarsals, because the head is already getting so much pressure, the shaft gets minimum to none pressure. So we're putting a little extra pressure on the shaft and taking the pressure off of the metatarsal head, pretty much expanding the surface area on pressure.
Right.
And then your simple silicone toe sleeves. I think these are great, especially for those dorsal calluses and pressure sores that you can get, especially with the shoe gear. Works very, very well. Just like the silicone 4-foot pressure pad, it's an extra thick layer of gel of silicone to act as a barrier, pretty much, because the top of your toe has very little skin to it.
Right. And the other thing they're nice for is people who are getting those calluses in between in the inner space.
Oh, yes.
Yeah.
Yes.
Just spreads the toes apart. Yep. Those soft corns in the inner space. But, again, those soft corns are a result of a bony problem underneath, and all this is doing is padding the area and slowing things down from a callus standpoint, but not eliminating it.
Yeah, it's not correcting the problem. It's adding, cushion to it. For those patients who, I'm a teacher, I want to do my surgery summer vacation, I think these are great things to use, so you'll buy you a couple months and get you comfortable in the meantime. There's a lot of taping options for hammer toes. They work. I don't think they fix the problem. I use them more for like plantar plate tears. I think they work well.
Well, and they're also nice post-op. So if you need to retain that position for a while longer, maybe you still have some skin that needs to be stretched on the top of the toe, the scar may be contracting. These work great for kind of...
Yeah. Do you use tape or do you use the Coban trick? I like the Coban trick where you kind of make a giant loop and you crisscross it around the toe and then bring it around the heel and I'll hold it in place.
I've done both, but I also like taking 1-inch athletic tape, splitting it in half longitudinally, and then doing like the breast cancer ribbon.
Yeah.
So one loop around the toe and then it crisscrosses underneath the foot so you're not encircling the toe. Mm-hmm. But that crisscross allows you to then kind of tug the toe in whatever
you do it
position.
laterally.
Yeah, you can. It's like reins on a horse. You can kind of and redirect the toe, centrally, and then hopefully stretch whatever is contracting on top. So yeah, I use that mostly post-op though.
Yeah.
Trying to control the skin contractures while we're letting things heal.
Yeah, there's not a lot you can do, conservatively to fix the hammer toe. They're pretty much cushioning the problem.
Yeah, you're buying time, or the patient's just not a good surgical candidate, and this is the best you can do.
So soft tissue options. So this is something that we typically do in the clinic. I try to reserve these more for the older geriatric patients. In the young, I give them my spiel. This is a short-term correction. These are known to come back, 5, 10, 15 years down the line. This will buy you time. This will take the pressure off of those areas, and it does work well as long as you have a flexible hammer toe contracture.
Right.
So, there's a multitude of ways of doing this, and it just depends on the type of hammer toe you have. Most commonly, we'll do like the plantar incision. We'll release that flexor tendon, and that will take that contracture and let it sit a little bit straighter. Now, some people go ahead and will release the capsule while they're in there. I do the same thing. I do the PIPJ, and I'll just release the capsular ligaments while I'm in there. You'll put 1 or 2 stitches in there, and it works great. Now, when you have the extensor tendon problem, you do the exact opposite. You go up top, and you release the extensor tendon. Like I said, this is a short-term solution because those tendons will scar back in, and there's a high chance of those recurring 10, 15 years down the line. Mm-hmm. I don't know. What is your opinion on this?
Yeah, I think for wounds, they can be real helpful for that patient that's just not a good surgical candidate.
Exactly.
We've worked, like the patient that I have to take back to the OR.
Yeah, like the...
We did that on his second toe, and it worked great. But there was, clearly there's a charge for that. and it was going to be less expensive for him to go to the hospital than to have us do it in the office, which was weird, but it was just the way his insurance worked. But yeah, it worked great for his second toe, but now, then he ulcerated under his third. So now you got a transfer lesion because his third, fourth, and fifth toes are still horribly contracted.
I'm glad you said that, because a lot of people don't think about that. So when you do your flexor tendon release, now, so all of those tendons come through, and they
conjoined tendon.
Yeah, they're in a joint tendon. So if you release one, now the remaining tension is on the other ones. So there's a high chance that the other ones will start getting the pressure sores and hammering and getting that callus. So we definitely have to explain to patients that this is a likelihood. This is something we have to be aware of.
Right.
You may have to wear a crest pad preventatively. You may have to do your stretching exercises preventatively, and or the orthotics. Whatever we can do to make sure that it doesn't happen to the other toes, because you don't want to fix one problem and then cause a different problem, you know?
But very common with toes,
Yeah.
Yes. I think hammer toe surgery, you're looking for a ballpark, you're not looking for perfection.
Yeah, hammer toe surgery is one of those, you're balancing tendinous work and bony work. Mm-hmm. Yeah, with bunions, ankle fusions, midfoot problems, fractures, etc. that we're doing, flat foot surgery, most of that is like bony realignment. Tendon balancing is not as big a component to most of those surgeries. As far as hammer toes go,
it's
I
crucial.
think 50% of the procedure is tendon balancing.
Right. Absolutely. As far as outcomes are concerned, yeah. Absolutely.
So here kind of some before and after. I found these online, just very simple. They did your plantar releases, and you can see I think this is like 6 weeks out, and this is like 3 months out. I don't remember offhand, but as you can see, the hammer toe deformity is, corrected to an extent. It looks like this person here on this side had the callus on the tip of their toes, and they released. It looks like the second and third, I guess, on these ones. It doesn't look like they did the fourth or fifth, but obviously you can see that the toes are sitting a little bit straighter.
The goal is to just make sure you're weight bearing on the fat pad again, because the tip of the toe has very little, if no, fat pad. Yeah. So you weren't meant to bear weight on the tip of the toe. You're meant to bear weight on the plantar aspect of the toe where the fat pad is. So anything you can do to straighten the toe, even just a little bit, and improve where the weight bearing surface currently lies, is going to make a huge difference. That's why you get that really nucleated, painful callus on the end
so
of the
tender.
toe. Yeah, because there's just no fat there. Yeah. No protecting the end of the toe. So your skin's reaction to that is build up more layers of skin. That's what a callus is. So, that there's a friction and a pressure component that causes that reaction, that your skin is basically just trying to protect itself.
Yeah, and it's a vicious cycle, because now you're trying to protect itself. You build the callus. The callus ends up being a prominent spot, which allows for more pressure, which causes it to make more callus. And that's why these things recur quite a bit.
Right. And there's sensory nerves right in and around and under, and so all of that.
Yeah, the plantar surface of your palmar surface, your hands and your feet, have exponentially more nerve endings than most your skin. Right. So that's why you can feel like a grain of sand, in your shoe. You can feel like a hair between your fingers, but you won't feel a hair on your arm. It's just it's the way we're made. So simple surgical options. These are simple as far as this is the first stages of hammer toe correction. You can do what's called a arthroplasty or orthodesis. Arthroplasty meaning you'll release the joint, you remove that portion of bone, and either you'll fold in the tendon or capsule, or you'll leave it loose, and you'll still have flexion mobility. I've kind of fallen from doing those too often because they just tend to recur.
Right.
I just end up going straight for the fusion, the orthodesis, only because the long-term results are great. And
I think most people aren't going to miss that motion. What you still have is motion at your MTPJs, right?
But yeah, or your DIPJs.
Or the DIPJs, but you won't be able to pick up pencils with your toes anymore.
Yeah, it's not like you're writing letters with your feet.
And thankfully, picking up pencils with your toes is not a job requirement for most people. So, you're not going to miss that motion, and straightening. Clearly, we're doing this for pain. We're not doing this for purely cosmetic reasons, because that wouldn't be covered by insurance. But the pain component actually gets better pretty quickly, and having the pins in place, and that you can see in that picture, it looks a little Frankensteinish, but once the pins are in place, they're not painful.
No.
Patients do really well. And
most patients, I mean, especially when you pull them out, they barely even notice it. They're like, is it going to hurt? I was like, honestly, the only nerve ending is only at that tip of that skin. Your bone doesn't have nerve endings. Your tendons don't have nerve endings. I mean, sensory nerve endings. So you're not going to feel pain when we pull those out.
And the bone heals around them.
Oh, yeah.
It doesn't usually stick to, so they're pretty loose after 4 or 5 weeks, and you can slide them out in the office really pretty simply. So that doesn't usually require another trip to the operating room, and it provides the correction that you need. And if you have, we don't have a picture of that, but if you have both the metatarsal phalangeal joint contracture and...
Well, that's what I was going to ask you. Why would you determine a long K-wire versus a short K-wire?
If you're correct, if you're doing anything to correct the MTP joint, so if you're releasing the contracture there and you're lengthening the extensor tendon, you need to drive that all the way across. That's my biggest complaint about implants, is that most of the implants don't allow you to do that. And so you can get a nice straight toe that's sticking up. Yeah. And that's not going to help.
So that's when we go back and we do our extensor releases, and we'll get into that.
So the far left one shows that. Yeah, you've advanced the K-wire across both joints, and so you the nice thing is you can correct both joint positions with that $5 implant. I mean, yeah,
it's like a paper clip.
Yeah, they're cheap.
So here are the implants. There's a multitude of implants. I didn't pick any one of these specifically. I've used, I think, one of everything. They're all pretty much the same. My general rule of thumb, I mean, same thing like you just said. I do like the cannulated implants. The cannulated implants are the ones that have the hole down the center. So if I did need to do the MPJ, I wouldn't have to, try to...
Wouldn't have to compromise. Yeah. You could use the implant. You could go ahead and put the K-wire through the implant and then correct the position and hold the correction of your metatarsal phalangeal joint. The nitinol ones, the little spring-loaded ones you have in that center picture, those work great. And I have patients who clearly don't want K-wires because they don't want anything sticking out of their toes. Yeah, those are great. But man, when if those get infected or those things break, it is a pain in the butt. Because trying to take those out and do a redo, much more difficult. And that can be the case with a lot of these implants because of the bony overgrowth. They're just tough. So they're expensive. I'm not a huge fan. I'll just be honest. I still stick with I guess it's because I think most of the hammer toe surgery I'm doing is pretty advanced. I mean, we're talking rigid, horrible deformity kind of stuff. I'm not seeing a lot of the real simple ones in younger patients. Because I think the implants in the younger patients who are trying to avoid having a pin sticking out of their toe for 4 to 6 weeks, that I'm just not seeing that many of those folks. I'm seeing mostly
because we're catching them early, we're correcting them, at the level of conservative options. What about these bony ones? These are our cortical bone implants.
I think that's interesting. I think that's.
And I think these are nice a similar option. Thing. I think this is a synthetic bone type of. I forgot what these are made out of.
Probably PEEK, which is absorbable.
Absorbable, yeah.
So I think those are interesting options. The nice thing is you don't really see them on X-ray, and if they work, you've got tremendous bone across your fusion site, which is great. Yeah. So I think they're a nice option.
Let's see what else. Oh, screws. So these ones I use pretty much for the real bad hammer toes. And these screws are typically cannulated also. Right. I don't know if I don't have any pictures in here with the K-wires, but what do you think about these type of fixations?
I like them again, but you can't fixate the MTP joint. It's like your picture here where they did the Weil. So they backed up the metatarsal head, they fused the PIP, and they fixed the interphalangeus deformity of the big toe. But that second metatarsal phalangeal joint, the ligamentous structures controlling that joint are gone on the lateral side. There's just no way they're still intact. So if you don't pin that straight, there's a chance for it to deviate again, and your nice straight second toe could then still cross over your big toe again, or get tethered into it. So I would like to see what that foot looks like in 5 years. Yeah, because it looks great right now
on X-ray,
but they didn't do anything to either augment or correct the lateral collateral ligament damage that clearly allowed the toe to go whoop. So we'll see. And maybe they did. Maybe they
this
did
is
a
a couple weeks out. I don't know. Maybe they pulled the Kwires after.
Well,
this.
they may have done a girdle stone or some sort of
Tendon
flexor
transfer.
tendon transfer with that. And if they did, then that was smart. That has a much better chance of long-term solution, long-term good outcome.
Yeah. So pretty much when we do the Kwires, right, and you put it across that MPJ joint, what we're waiting on is when we release those ligaments and realign those tendons, that apparatus to pretty much scar back into place.
Right.
So it pretty much makes up that capsule once more, just out of scar tissue, fibrous tissue, which over time will turn back into capsular ligament. But yeah, I agree 100%.
Yeah, so that's a beautiful result on the right there. That's probably immediate post-op or maybe a couple weeks after. But I'd like to see what
out because you still see the gaps between the joints.
I'd like to see what that looks like in 4 or 5 years.
Yeah. So additional procedures. So we're talking about the toes specifically as far as those procedures go. But what are some other procedures that we do? So we talked about the tendon balancing, and we've been talking about this. I mean, that last case, I am positive they had to go in, lengthen those tendons. So I don't know what you do. I do instead of the Z lengthenings, I end up doing the extensor long and the brevis short, and I overlap them. Some people split them down the center. I don't know.
I do the long. I do a long Z.
Yeah.
So
Is it the long Z right here?
Yep.
You can see that Z cut.
Exactly, and then it gives you, the length you need by just essentially stretching the tendon, and then you suture that. I suture that back with monocryl, and I've released the underlying joint capsule and
the capsular ligaments.
And then when you pin it, then you can easily repair the tendon in a elongated position.
Yeah.
So I do that almost on every single case where the MTP joint or the metatarsal phalangeal joint's involved, for sure.
Yeah, it's a common thing that we do with hammer toe procedures. So a lot of times the patients be like, oh, you're just gonna do a small incision across the top of your knuckle. Yes, unless there's additional problems associated with the hammer toe problem.
And I'll do them through 2 separate incisions.
Yeah, of course.
So the PIP I do an ellipse, which I can hide the scar in the normal skin line, which is great.
100%, I agree.
From a cosmetic standpoint, especially for women who want minimal scarring, it works great, and you can barely find that scar in a year.
And what about on top of the toe? I mean, on top of the MPJ, do you do lazy S?
I do a little C or a lazy S,
yeah.
And those heal up beautifully. And again, because it's not a straight line that can get contracted and become a bad scar, it's a curved line that if it gets contracted, it becomes a straight scar.
Yeah.
So just another little technique that we've borrowed from plastics.
Yeah. And they work great, simple, effective. But this is that stuff we're talking about, that balancing of those tendons. Here's another osteotomy that we typically do. It's called a Weil osteotomy, where if the second metatarsal is elongated, it also puts you at risk for getting those hammer toes and that metatarsal, the plantar metatarsal pain. So what we'll do is we'll slide them back or over, depending on the angulation problems, and we'll put a screw or 2 across there. Simple, effective. And then while we're in there, we're rebalancing that capsule and tendon. You can see this person here, the before and the after. It's great. It's here's the before and after.
That's a nice result. Yeah.
Yeah. It's simple. You can see that they shifted the heads slightly medially, I guess, to maintain that parabola a lot better. But it works. Here, this is probably the more common way that I'll do them. I'll do the single screw, but I'll do the K-wire across that joint to actually let that capsular ligament kind of hold them in place.
And then that's a nice over-engineered lapidus.
Yeah.
So that's a fusion of the first metatarsal cuneiform joint back there with a plate and screw construct, which is going to be nice and solid. And they clearly got good bone healing with that. The first ray is a little short, but if they plantar flexed it or really declinated it, and you can really mitigate some of that shortening.
Yeah, or they may have had the lapidus in the past, and that caused the shortening.
True.
Or whatever. I guess they may have done like a Youngswick here. I don't know. Whatever.
Looks like they may have done a combo. Yeah.
But so sometimes when we do these surgeries, or other surgeons do these surgeries, you're at risk for shortening that metatarsal, and it's a known risk, and we try to do our things to help mitigate that risk. Plantar flexing it, making sure we don't take too much bone. but it is a known risk. And usually your second metatarsal is slightly longer than your first. And if it is known that we're going to do that procedure, you're like, well, I might as well correct this problem while I'm in there. You'll go ahead and you'll shorten that metatarsal, so you'll have a natural curved parabola. And I mean, this person, this looks great.
You eliminate a lot of the pressure point issues with doing that. Yep.
Yeah.
That's a nice option.
Recovery. So hammer toe surgery, although it is simple surgery when we're talking about small joints, it is it's still surgery. So I typically will have patients in boots for about 6 to 8 weeks. I don't know about you.
Just post-op shoe usually, but you really got, if you're using that Kwire, they can't walk barefoot and they have to use the shoe, or they're going to flex that thing and fracture it. And I've had, it's probably 3 or 4 patients a year where they don't listen and they fracture that pin.
That Kwire is coming back, back here, and it's a very thin wire, and they'll walk and they won't realize that it's flexing. So it toggles that wire, and if you ever played around with the paperclip, you toggle it once, twice, 3 times, and it ends up just snapping.
Right.
And that's what ends up happening.
Which is not the worst thing in the world.
If it's buried in bone.
If it's buried in bone, it's not going to ever be an issue. But, you look at the x-ray later on, and you're like, oh, what's that floating piece of metal in my foot?
Yeah.
Should have been a little more compliant.
Yeah. I'm more on the surgical boot side.
I think they're great. I think that's not a bad option.
The only reason I like the boot better than the shoe is just because it's easier to walk in. I've worn it personally for shoe and boot, and the boot has that little rocker to it, and I think you can just walk a lot easier. And I don't know, it's just my personal preference. Some people will be in crutches, some people will be in knee scooters, depending on the associated surgeries that they might do, like the lapidus. Right. Get to be off of it for quite some time. Some people will put them into casts, slipper cast, full leg cast.
I put them in a full short leg cast with lapidus, just to move all of that weight onto the tibia that we can. Mm-hmm.
But the recovery for the surgery isn't long, isn't hard. You just have to do what you're supposed to do, and it's pretty straightforward.
The downside, if it's your right foot, always, you got to remember, if it's your right foot and you're having forefoot reconstruction, whether it's bunions or hammer toes, you're going to be out of commission from a driving standpoint for a while, and that you have to build into your expectations. So a lot of folks kind of fail to remember that. So that's something to keep an eye on. Whenever we're doing stuff like this on your right foot, you really can't be driving. And not just because you might screw up the surgery, but if you got into a car accident and injured somebody,
certain states you're not allowed to drive with a boot on.
The civil lawsuit risk would be significant, so it's just not worth it. I did not know that. So there are state laws.
New York, New York and New Jersey, I'm fairly certain you can't drive with a boot on.
Wow.
I think Texas you can technically drive with a boot on, but I mean, if we want to coat you,
I don't want to hear that. Yeah. Patients tell you, well, I've been driving. Like, no,
I tell them, do not drive. Yeah. If you have a boot, you've had surgery, if you're on pain meds, I'm telling you, do not drive. Get yourself a driver. There's Uber, there's Lyft, there's a lot of different ways you can get around.
There's Uncle Bob.
Yeah, Uncle Bob, yeah. But I mean, as far as hammer tests go, anything else?
I think that nailed it. I think, they're not just a cosmetic problem. They are a mechanical issue. There's a hereditary component, obviously, with a lot of folks. But we're able to address both the cosmetic aspect of it and the mechanical aspect of it, which is a nice win-win for the patient.
Yeah.
I think that's beautiful. That before and after is wonderful. You can see that we clearly, you're able to address the calluses, but the underlying bony architecture that was causing the callus formation. And, that patient's got to be thrilled. That's just a totally different foot.
Yeah.
So, stop hammer toe. Yeah, we call it beautifying America from the ground up. That is the elimination of hammer toes and bunions from the world.
Saving the world one toe at a time.
There you go. All right, Dr. Hussain, thank you very much. We are the PODdoctors, and we will see you guys next time.
Take care.